Hello and welcome to this webinar brought to you by myself, David. I am the anaesthetist at London Vet Specialists, and in this 1 hour session we are going to talk about emergency anaesthesia, so for commonly presenting emergencies that you may encounter in practice, and I will give you some tips on what to look out for during those specific surgeries, as well as how to try and stabilise the patients beforehand, and some examples of anaesthetic protocols that may be appropriate for each case. So just an outline for the webinar, and first of all we'll look at benefits of being prepared, and how you can assess and reduce the anaesthetic risk to the patient. And then after we've discussed a little bit about preparation and safety, we'll move on to specific case examples. And when I was doing my additional training in anaesthesia, one of my supervisors always spoke about the 3 Ps of anesthesia. So that was preparation, preparation, preparation. And this is really the way that you can minimise any errors and increase the safety to the animal that's about to undergo anaesthesia. And that applies to preparation of the staff that are going to be involved in the case, as well as preparation of equipment, the theatre environment, and also perhaps most importantly preparation of the patient themselves. So in order to prepare staff, make sure that everyone is aware of what is occurring. If there is an estimated arrival time for the patient, then we can have a target to work towards in order to make sure that everything is ready to go. We need to know how severe the incident is. That will give us an idea of what sort of equipment we need to have ready. It's important to delegate tasks, and specifically trying to assign the correct people to the correct task. You don't want to assign quite a straightforward task to one of your team members who is highly skilled in another area that you might require later, therefore meaning that they're unavailable further down the process. But things that can be delegated include reviewing the recent clinical history of the patient, preparation of basic life supportive treatments like fluids and oxygen therapy, and preparing the trays ready to anaesthetise the patient. When the animal arrives, someone can quickly triage that animal and perhaps take them through to the prep room to begin stabilisation, while the clinician involved in the case can take the history from the owner. So in order to prepare your environment, you want to make sure that the anaesthetic machine is set up and it's been checked that it's functional, and make sure that all anticipated surgical equipment is available. You can prepare adjunctive drugs in advance, such as antibiotics, antiemetics and so forth, and also at the very least have emergency drug doses calculated, and you may consider drawing these up beforehand if you have an accurate weight for the patient, if the animal is deemed to be in a very critical condition. And all of these things can be done before the animal even arrives in the building. So why should we prepare? There are 2 main factors, and the first are patient factors. So these animals that are arriving in an emergency setting are usually already quite compromised, so they're going to be at an increased risk of having an adverse event under anaesthetic. And if you can try to minimise, or you want to minimise any errors that you will probably make as a human. We're all prone to making errors, but if we can minimise our errors, that will reduce any severe morbidity or mortality to that patient. We also prepare in order to try and, as I say, reduce these errors that the caregivers are going to make. So there are provider factors to counter. Emergencies are inherently stressful situations, and interestingly, human performance is increased by stress up to a certain point, before it then drops precipitously. And this is going to increase the risk of errors. So we can classify the patient risk. As I say, emergency patients are generally going to be at higher risk of morbidity. And we can classify that using the Association of American Society of Anesthesiologists physical status classification. It's been modified to apply to patients. You're probably using this now, and it ranges from 1 to 5, and 1 being a healthy patient, 5 being one that is moribund and not expected to survive, and it has the E classification if that patient is undergoing an emergency procedure. So various studies have tried to assess the risk of adverse outcomes under anaesthesia, looking at the ASA status in both cats and dogs. And probably the largest one of these is it's quite old now, but it's from David Broadbelt back in 2008. And they identified several factors which may increase or decrease anaesthetic fatality, perianaesthetic fatality. The two which are most relevant to our talk today are the fact that if it's an emergent procedure, the odds ratio of perianaesthetic mortality is between 1.6 and 3, so 1.6 to 3 times more likely that the animal will die in the perioperative period if the procedure is emergent, and the range is based on whether it's a cat or a dog. So I think it was a 1.6 increase in risk for cats and 3 increase in risk for dogs. And additionally, the ASA score of greater than 2 was associated with between a 3 and 6-fold increase in risk, again depending on whether it was a cat and a dog. And most of these emergency cases that we're going to discuss are going to fit into ASA classifications which are greater than 2. So as I say, the human factors, when we talk about stress, this is the Yerkes-Dawson law, which states that although for simple tasks, ones which you can do automatically, increased stress or arousal will improve performance, whereas complicated tasks where you're having to make decisions, where you're having to use active working memory to remember things and how that's going to affect other scenarios, these difficult tasks actually, the performance drops very quickly after a certain level of stress is encountered. So one of the things that can improve performance under stress are what are called the non-technical skills. These are social and cognizant skills which complement your own technical skills as vets and vet nurses, which allow you to undertake a task more safely and efficiently. They're sometimes quite unfairly called soft skills because they are extremely important in stressful situations. And these include task management. So you want to focus on the task at hand. You want to ignore all irrelevant outside distraction. It's important to be paying attention to your surroundings, but it's also important to quickly shut out anything that you've determined to be not related to this critical cause. And you want to manage your team. So you discuss roles so that everyone knows what they're doing, and discuss the critical steps in the procedure with all the team members that are going to be involved. Teamwork is important. That allows appropriate staff delegation, and it's important that you coordinate your task with the other members of the team. So simple things like checking the patient under the drapes while the vet who's doing the surgery is doing something particularly delicate. You have to be aware of how your actions are going to impact on the other team members. Situational awareness is the perception of events which are occurring in respect to time, and this is a dynamic situation. So when we're doing anaesthesia, we're thinking about the patient's current status, what is happening to the patient at the moment at this point in surgery. We're taking in all the parameters, we're assessing that yes, the animal is safe at the moment, but in 10 minutes time, when we move on to the next step in the procedure, are these parameters still going to be considered safe, or do we have to act now to try and improve the patient's parameters in order to tolerate the next step in the surgery? Decision making is another important non-technical skill, and that includes the constant process of data collection, risk assessment, decision making, and then most importantly to reassess if your decision has been effective and to reassess the situation. So always repeating in order to stay ahead of the game. And then finally, communication. This is a major cause of perioperative error and perioperative morbidity. So we'll look a little bit more closely at that. So as I say, poor communication is the main cause of errors in the operating theatre. And in order to effectively communicate, you want to make sure that your communication is clear, so clarity is important. You want to use objective and technical language so as to avoid vagueness. You want to be to the point, so the message should be brief. You want to deliver it in a way that is not going to make the team members scared of you or feel offended, so you have to have some degree of empathy. And you should use closed-loop communication. So when you ask for something, in an ideal situation, the person you are asking will repeat your request back to you, usually paraphrased so that they're not using the exact same wording, so that you can assess that they have correctly understood, and then you give an affirmative or a negative response to state whether they have understood your request clearly. You should also use absolute directions, so call people by names at the beginning of the request or statement in order to get their attention. And overall, we want to provide an environment where everyone feels that they can speak up if they notice a problem and they don't feel inferior to any other team member. And because when you're setting up and performing these procedures, they are tasks which are made up of multiple smaller, maybe even simple parts, it's really important to forget any of these. So it's important to have an example, or to have a checklist, sorry, to make sure that all critical moments are completed, or all critical tasks are completed appropriately. The checklist, which I'll come on to in just a moment, an example of one, should be performed in a quiet environment, so in the operating theatre, for example, with the team's full attention to the checklist being completed, and should occur at a point where there's a natural pause in the procedure. So the obvious points to check in and check progress include just prior to the induction of anaesthesia, just prior to the incision in surgery, and then prior to the patient recovering from anaesthesia or leaving theatre. So this example checklist is taken from the Association of Veterinary Anaesthetists website. It's available to download, and as you can see here, it covers all of the important things to make sure have occurred before we proceed with the case. So it's split again into 3 points: before induction, before surgery, and then before recovery. So now I'll move on to actual case examples. I'm sure it's what you all came for or listening for. And I've just tried to select a range of things that you might encounter in practice. And the protocols that I suggest are the way that I would generally approach the case. There is more than one way to do things, so I'm not saying that this is the guidelines that you have to follow, but at least I hope it highlights the rationale behind how I'm trying to counter the common complications in each of these specific scenarios. So the first one, we look at Hemo Abdomen. So this is Bella. She's an 11-year-old Staffordshire Bull Terrier. She's had a chronic history of lethargy, which the owners have put down to old age. She's just slowing down, but this morning she had a peracute collapse, so she collapsed and struggled to get up. So on clinical evaluation, the temperature is a little bit low, heart rate probably within normal limits for a stressed dog. Respiratory rate is increased, her mucous membranes are pale, and she has an appropriate capillary refill time. And when you're palpating the peripheral pulses in the metatarsus, they feel weak, and you take blood pressure with the Doppler blood pressure monitor, and that reveals a systolic blood pressure of 80 millimeters of mercury. In this case, there was some imaging available, so abdominal ultrasound revealed a peritoneal effusion, which was tapped and revealed blood in the abdomen. So treatment can begin immediately with fluid resuscitation, even before the ultrasound, of course. We would have instigated some resuscitation with intravenous fluids in the first instance. In terms of testing that we want to perform before proceeding with any surgery, you want to know the patient's hematocrit or packed cell volume, bearing in mind that if this is a very acute bleed or if it's ongoing, then the drop in PCV is going to occur later, so you're not measuring the actual patient's likely situation in the next half hour as you continue to fluid resuscitate her. And when we take the tap from the abdomen, you can compare the PCV of this abdominal fluid with the peripheral PCV to get an idea of whether it is frank blood that you're dealing with. Typical biochemical aberrations that are going to occur in this case might be a mild pre-renal azotemia, and it can be progressed to marked or moderate, depending on the severity of the blood loss. And because some tissues are likely to be deprived of oxygen, we often see an increase in lactate. The hematology reveals an anemia and a stress leukogram, and also there is a thrombocytopenia on the hematology machine. However, on slide assessment, the platelets are found to be adequate in number. You may consider to do coagulation testing. If this has been a chronic bleed, then there may be some consumptive coagulopathy, although that is in practice is quite rare, but it's probably worth checking the coagulation times. You may choose to blood type the patient, and we're going to have to decide whether the patient is stable enough to proceed with the surgery now, or whether perhaps we have to transfuse the patient before going for surgery. And deciding whether or not to transfuse is often quite difficult. There's no magic number that allows you to say, yes, I am going to give this patient blood products. As I say, initially we tend to give crystalloid resuscitation initially, and that's likely to drop your PCV from what was measured when the patient first arrived. We need to consider, if we are going to give blood products, which ones are we going to give, or what do we have available to us. Most small practices won't have a full range of blood product, so you may not have much of a choice. And you can consider, when you finally get to surgery, if you don't have blood products available, then you may be able to do, if it's a large abdominal effusion, you may be able to do an auto transfusion, so where you take the blood from the abdomen and transfuse it back into the patient. And you'll be able to find details of how to do this safely. As a general rule, there are filters available which allow you to transfuse blood even if it has come from, say for example, a ruptured spleen which was cancerous. You do get filters which will filter out the neoplastic cells, and you have to weigh up the risk versus benefits anyway. If the patient's going to die from acute hemorrhage, the benefit of giving them that blood probably outweighs the risk of causing metastasis by infusing neoplastic contaminated blood. In terms of how much blood we need to give the patient, we try to target a goal PCV, so something that is probably, you may not be able to get it up to back within normal limits, but you want to increase it towards normal. And for if you're using packed red blood cells, for every 1 ml per kilo you give the dog, you should increase the packed cell volume by 1%. Compared to fresh whole blood, that would be a dose of 2 ml per kilo, increasing the PCV by 1%. And if you do decide to transfuse the patient, you want to consider potential side effects, which can be immunogenic, so true allergic reactions, or non-immunogenic, such as volume overload, or if the blood is given over an increased period of time, you want to make sure that you handle the blood appropriately so that it doesn't become contaminated with bacteria. So volume overload or infection can be non-immunogenic side effects of transfusion. As I say, there's not really an easy number to go with which will tell you to transfuse or not, but I find that this is quite a helpful table from the Journal of Veterinary Internal Medicine. And the table basically is moving from left, which is the desirable state, to right, severe, severely affected, and then the different parameters that you can look at. And if these are tending towards the right, that's going to make you more likely to want to consider a transfusion. So if they're pale, the pulse quality is poor, and they're tachycardic and tachypnic, and if they are with reduced mentation, then this is going to all be pointing towards that transfusion might help this dog before surgery. The reason that we're wanting to give blood is because you can see from this equation, which is quite complicated, but this is basically the oxygen delivery, which is dependent on the cardiac output and the oxygen content of blood. The most important number here is the hemoglobin concentration, which is because virtually all, 98% of your oxygen is carried by hemoglobin, so the actual administration of oxygen to an anemic patient is not going to help you that much because as you can see on the very right of the equation, very little of that oxygen is actually dissolved in the plasma. So increasing the hemoglobin concentration is definitely the best way to improve oxygen delivery to your patient. So anticipated complications in hemoabdomen surgery. You're quite likely to encounter hypotension, especially if you haven't been able to completely fluid resuscitate or volume resuscitate the animal beforehand. You will want to be giving fluid therapy and also consider vasopressor use. However, it's important to remember that we probably can tolerate a little bit of hypotension in this scenario, at least until the source of the hemorrhage is controlled. There's not a lot of, or I don't think there's any evidence for the technique of permissive hypotension in veterinary species, but in human patients they will allow some degree of hypotension in order to try and decrease the amount of bleeding that's happening before the surgeon is able to locate the source. We've spoken about how anemia is going to affect, or how hemoabdomen is going to affect your patient's oxygen carrying capacity, which is going to reduce oxygen delivery to tissues and cause a anemic hypoxia. So the treatment for that would be blood transfusion. Again, there can be limitations with the availability of blood products, particularly in cats, but if it's available in your practice, you want to know that it's there and to make the decision on whether to use it or not. For a multitude of reasons, these patients can become arrhythmic. So in Bella's case, she had a splenic hemangiosarcoma, and it's thought that some of the inflammatory mediators produced or caused by this neoplasm may irritate the heart, so they're more likely to have arrhythmia. But also, if the patient is very anemic, it's likely that the heart tissue is being is receiving an inadequate oxygen supply at a time when it's having to work quite hard to get the remaining blood and the remaining oxygen around the body. So that poor oxygen delivery to the heart combined with increased work from the heart is going to irritate the myocardium and cause arrhythmia. Additionally, pain response is going to increase sympathetic nervous system activity and increase catecholamines such as adrenaline, which are arrhythmogenic, so they're going to increase the risk of arrhythmia. And when you see an arrhythmia, they're usually ventricular premature complexes. We need to decide, are we going to treat these or are we able to tolerate those? So the first thing to rule out would be a pain response. Try and give supplemental oxygen if you're not already in theatre and providing 100% oxygen. And whether to use antiarrhythmics, the first line would be lidocaine. You have to decide how frequent are these arrhythmias. Are they causing a hemodynamic consequence? So is the blood pressure markedly reduced while the arrhythmia is occurring? And what do they look like on the ECG? So if they look all the same, then these tend to be a little bit less worrisome because it's just one particular part of the heart which is irritated and generating an extra beat, whereas if they're all looking very different, so both positive and negative on the ECG, it suggests that there's a more global problem within the heart, and this can be more dangerous. So I would probably be more likely to treat with lidocaine, 2 mg per kg, if the ventricular beats were polymorphic. Because of the effect of the bleeding in the abdomen and increased volume of the abdomen, you may struggle with hypoventilation. So you may require to give the animal a little bit of help with that with some IPPV. And potentially you can decompress the abdomen, although this is usually done when the abdomen is open, particularly if you're hoping to collect the blood for autotransfusion, which we touched on a little bit earlier. It's worth bearing in mind that often at this point, when the abdomen is initially opened and you get this sudden decompression of the abdomen, the patient can tend to be quite hypotensive at this period, so it's worth being primed with and ready to give a fluid bolus in this instance. And the patients, because they've initially been very vasoconstricted whilst trying to centralise their remaining blood volume, when you give this vasoconstriction causes the periphery to become very cold, and then when you give anaesthesia, you get vasodilation, and the blood returns to these cold limbs and can drop your temperature quite markedly. So you want to be quite aggressive with the warming of the patient during surgery. So in terms of anaesthetic protocol for this case, I tend to go just for an opioid pre-medication, and it should be full mu agonist because we are performing a laparotomy. So I would go 0.2 to 0.3 mg per kg of methadone IV, and bearing in mind that acepromazine and medetomidine are both going to be contraindicated. Acepromazine because it's going to take away the animal's reflexive vasoconstriction to try and maintain centralized blood volume, so we're going to get a drop in, like a marked drop in blood pressure. And medetomidine contraindicated because even small doses of medetomidine will decrease the cardiac output significantly, sometimes up to 50%. And if we remember back to our oxygen delivery, it's our cardiac output that has to increase in order to compensate for a decreased oxygen carrying capacity of the blood. So you want to avoid anything that's going to markedly decrease your cardiac output. Acepromazine is not the only drug which causes vasodilation. Sadly, most of our anaesthetics do. Propofol or alfaxolone are appropriate for induction of anaesthesia, but because they can cause vasodilation, we maybe want to give an additional drug which will reduce the dose that we have to give and hopefully minimise the amount of vasodilation. So you can combine the propofol or alfaxolone with midazolam, and I usually use 0.2 mg per kg IV. If the animal is quite quiet after the methadone, then I'll give the midazolam first, and then after a couple of minutes induce with propofol. But if they are still very awake, I might give 2 mg per kg propofol and then the midazolam, and then top up with propofol if it's not enough to anaesthetise and intubate the patient. For maintenance, you're going to use your volatile agent which you have available and have most familiarity with. Both of them are going to cause vasodilation, but they don't require significant metabolism, so the recovery from those agents should be quite quick. I would consider adding in a lidocaine infusion in the rate between 50 and 100 micrograms per kilo per minute. This is going to give you good isoflurane and sevoflurane max sparing effect. So if you go with 100 microgram per kilogram of lidocaine, you may be able to get away with a 25% reduction in sevoflurane. There have been some studies which have shown this. In order to estimate blood loss, because even if you decided that they didn't require a transfusion before, that situation can change. So you want to, methods of estimating blood loss include counting swabs, so the normal sized small 4x4 inch swabs when saturated carry around 10 mils, whereas the larger laparotomy swabs can collect up to 75 mils when saturated. If you're using suction, then you can take a sample from the suction jar, so just agitate it to make sure that it's well mixed, and then run a PCV on the suction. If you divide the suction PCV by the animal's peripheral PCV and then multiply that by the volume in the suction jar, this will give you an estimation of blood loss. And then we have to consider what is that in relation to the animal's circulating blood volume. Depending on where you look for this figure, the value may vary slightly, but generally the circulating blood volume of a dog is around 90 mils per kilo, and for the cat it's around 70 mils per kilo. When you have your value for how much you've lost and how that relates to the animal's circulating volume, an acute loss of 30% blood volume is probably a reasonable trigger for transfusion in a healthy animal. But if you calculate you've lost 30 in an animal that's already had blood loss prior to surgery, I would say that you're almost certainly going to want to increase, or you're certainly going to want to transfuse, or at least be on the phone to the pet blood bank ordering blood for this patient in the recovery period. So for post-op care, alongside your normal sort of pain assessments and TPR checks, you may want to continue with ECG monitoring, particularly if there have been arrhythmias in surgery, and then keeping an eye on the PCV at least a couple of times in the first 12 hours just to make sure that we have achieved hemostasis, bearing in mind that we're expecting the PCV to drop as the blood volume returns to normal with crystalloid support. And yes, you want to make sure that you are doing regular TPRs, especially if you've decided to transfuse the patient, just to detect any transfusion reaction. So moving on to the second case of a uroabdomen, typically involving cats hit by cars. Zeus was a young, adventurous male domestic shorthair who had gone missing for 2 days, and when he returned home, he was very, very lethargic and brought to the vets. So his demeanour on arrival was obtunded. He was hypothermic with a severe bradycardia of 80 beats per minute and an increased respiratory rate. His mucous membranes were pink, and capillary refill time was 2 seconds. When taking the Doppler, it was difficult to find, but eventually we found a reading around 50 millimeters of mercury. So because of the severe bradycardia, one of the first things I would want to do is probably to pop an ECG on the cat. On the top of the screen is a sinus bradycardia, but typically with these uroabdomen cats, we are concerned about atrial standstill. So we see a sort of escape rhythm and spiking of the T waves, which is not pathognomonic for hyperkalemia. I find that we see this not uncommonly on our ECG in normal patients, but it is very common when the patients are actually hyperkalemic. So in terms of testing for this patient, hematology revealed a PCV of 40%, a little bit dehydrated with increased total solids. There was a marked azotemia, so urea and creatinine were both elevated, and also an increase in ALT. Most concerningly was on the electrolytes. It showed a marked hyperkalemia of 9.8, with the upper reference level being 4.6. We were lucky to have access to blood gas analysis, which revealed quite a severe acidemia, so a pH of 7.2. And the cat, as I say, was quite collapsed, so it was able to tolerate a conscious X-ray, which showed an abdomen with reduced serosal detail, but no abnormalities found on the chest. An ultrasound-guided abdominal synthesis revealed a small urinary bladder, abdominal ultrasound revealed a small urinary bladder, and synthesis of free fluid found within the abdomen showed increase in potassium and creatinine compared to the peripheral blood. So the sort of tests that we can perform on here show that a 1.4 increase in potassium of the fluid relative to blood, or a 2-to-1 increase in creatinine, are extremely highly sensitive and specific tests for uroabdomen. So these cats become hyperkalemic because they've lost the ability to excrete potassium, and the definitive treatment of that then is to restore the urinary tract integrity to allow excretion to continue. Effects of hyperkalemia are progressive depending on the severity, with an initial change maybe only noticed on the ECG that you may not detect by auscultating the cat. But as that potassium increases, it will progress to a slowing of the heart rate, eventually to quite severe arrhythmias, including atrial standstill and eventually asystole. So treatment of hyperkalemia, you definitely want to do this before considering progressing to surgery. Uroabdomen in itself should be treated medically in the first instance in order to try and improve anaesthetic safety when the surgery to repair the bladder is performed. So initially you want to give aggressive fluid therapy to try and dilute that potassium out. Some people will prefer saline compared to Hartmann's. However, the amount of potassium in Hartmann's is low enough that its use is still fine in these patients, because you still will receive volume restoration without, you certainly will not increase the potassium by giving Hartmann's fluids as the fluid therapy in the first instance. If a severe arrhythmia is present, or if there is marked bradycardia or hypotension, then calcium is going to be the first thing to give, and that's calcium gluconate 10%. We can give 0.5 to 1 ml per kilo, diluted in quite a large volume and given over 5 minutes. You want to dilute this in saline, not in Hartmann's, because the Hartmann's can cause the calcium to precipitate. But you can give that slowly, and you should ideally with an ECG attached if you have it in the practice, and you want to keep an eye on the ECG as you give the calcium, because that in itself can promote arrhythmias. The rapid onset it has a rapid onset of action, so you'll usually start to see an improvement even before you're given the dose. And as I say, you can just give that nice and slowly to try and buy some time before you instigate a more definitive therapy, because the calcium is not going to decrease the potassium, it's only going to improve the implications of that high potassium on the animal. But it buys you some time in order to try and organise a treatment which is going to reduce the potassium. And that's usually going to be insulin with glucose. You can give neutral insulin, so fast-acting regular insulin, and you give 0.25 to half an international unit per kilo, and then follow that with a glucose bolus. And usually what we do is we give 4 mils of glucose per international unit of insulin that was administered. You want to keep a close eye on the glucose, and usually it's a good idea to keep them on a Hartmann's or saline, which has then had glucose added, just to try and avoid any inadvertent hypoglycemia. If you have the ability to measure blood pH, then if there is a severe acidemia, which was encountered here, you may consider bicarbonate therapy. The easy way to calculate the dose is it basically comes out at 1 milliequivalent per kilo, but this should only be given if the acidemia is severe, so less than 7.2, and because bicarbonate therapy does come with its own problems, particularly increased sodium, hypervolemia, hyperosmolarity, and if the patient is not intubated and you can't IPPV, then you may cause a hypercapnia with a respiratory acidosis. And additionally, you may cause if you overdose, you may move from an acidosis to an alkalosis. So in terms of protocol, you would want to stabilize medically beforehand, as I say, and that may involve abdominal drainage, abdominal lavage, urinary catheterization, just to stop any further urine entering the peritoneal space, and repeating of these anti-hyperkalemic agents if the potassium increases again. Hopefully with the medical management you're able to get these patients pretty stable, so they can often progress just as a normal XLAP. However, if the stabilization hasn't been perfect and the animal is still quite compromised, again I would avoid any pre-medication which has marked cardiovascular actions. So again I would probably just go with methadone IV. If the heart rate is still a little low, then I would choose alfaxolone, as it tends to keep a higher heart rate than propofol for induction. And again, maintain your with your agent that you have available in practice, so isoflurane or sevoflurane. You want to make sure that you are ventilating these patients adequately, because they do often have a metabolic acidosis. You don't want to allow them to hypoventilate, whereby they have a respiratory acidosis added on top and confounding the pH and dropping it even further. And again, you want to maintain your aggressive fluid therapy in order to try and dilute out the potassium. The third case is septic peritonitis. These cases are extremely challenging, and I would certainly recommend that if possible they should be referred to centres where there are multidisciplinary teams that are able to look after them both before, during and after the procedure, because they can be very challenging, and even in extremely well equipped practices with experienced teams, mortality does still tend to be high. So Ringo was a 6-year-old Labrador who is currently receiving chronic meloxicam for osteoarthritis, but he had developed an acute inappetence with vomiting and melena and extreme lethargy. On presentation, he was very quiet. He was tachycardic with congested mucous membranes. His pulses were very hyperdynamic, and the Doppler blood pressure was 70 millimeters of mercury. He had severe abdominal pain, which was also noted, and blood testing revealed normal PCV and total solids. His biochemistry showed a hypoglycemia, a mild azotemia, likely to be pre-renal, and a mild hepatopathy. He also had a mild hypokalemia, which wasn't deemed to be necessary to treat. His blood gas, he had again a severe acidemia, with a PaCO2 of 35 millimeters of mercury, so quite low, or towards the low end. He's trying to compensate for this metabolic acidosis, but he's not able to. The lactate was increased, suggesting poor oxygen delivery to the tissues. His coagulation times were normal. And on abdominal radiography, we noticed gas in the abdomen, which is indicative for surgery. So the initial stabilization again is going to be aggressive fluid therapy. Crystalloids are the preferred choice, and aiming towards a mean arterial pressure of 65 millimeters of mercury. You can consider colloids, but you should avoid synthetic colloids, as they may cause kidney injury, so fresh frozen plasma if available, especially if the animal is if the coag times are increased, or if the patient is hypoalbuminemic. Because this tends to be a painful condition, we need to make sure that we give opioid analgesia, so again, methadone usually. It's really important to start broad spectrum antibiotic therapy initially, as this is very time dependent, and the sooner we can get antibiotics on board, the better. In terms of blood pressure support, in addition to your intravenous fluid therapy, often these patients require vasopressor therapy to maintain a normal blood pressure, because they tend to have very poorly responsive vasculature caused by the sepsis. So in terms of goal-directed fluid therapy, we want to just give small boluses, assess what effect they've had, and repeat them if necessary. We want to try and normalize the heart rate and aim for a low normal blood pressure. It's unlikely that with fluid therapy alone you'll have better than just a sort of lowish normal blood pressure. Also keeping an eye on the lactate, as hopefully we will try and decrease that as we improve the peripheral circulation. So the cardiovascular collapse, in spite of adequate fluid resuscitation, is the septic shock. In human medicine, noradrenaline is thought to be the best pressor to use, and dose range is very wide. 0.1 to 2 micrograms per kilo per minute. It's preferably given through a large vein, as perivascular administration can cause tissue, can cause vasoconstriction and therefore reduced oxygen delivery to that tissue. But even despite the vasopressor therapy, often you still have a persistent hypotension, and this is because they have this vasoplegia syndrome where the vasculature just doesn't respond to the catecholamines anymore, and also the inflammatory mediators affect the heart, causing a cardiomyopathy, which means that the cardiac output may also, or the stroke volume and contractility of the heart may be reduced. They have this damage to the endothelial layer of the blood vessels. The endothelial layer is usually has this glycocalyx, which is important for controlling vascular permeability and maintaining normal coagulation, so neither hyper or hypocoagulation. But during sepsis, this glycocalyx barrier is often damaged, leading to tissue edema and disturbances in coagulation, such as disseminated intravascular coagulation in hypercoagulable states. The mitochondria also can be damaged, and you get this mitochondrial dysfunction whereby even if you deliver oxygen to the tissues, the mitochondria are not able to utilize that oxygen, so we have this cytopathic hypoxia. So really a lot of things going on that are very complicated. Speed of getting the animal to surgery, short anesthesia time during surgery are all extremely important, which is why I recommend potentially referring these animals to a centre where there is adequate monitoring facilities and experienced staff. So for a protocol, I tend to be quite opioid heavy on these patients, just to try and avoid having to use many vasodilating drugs. So for pre-medication, I would generally give 10 micrograms per kilo of fentanyl, so a very short-acting opioid, combined with midazolam IV. The fentanyl can be given over 5 minutes. And often, if the animals are really sick, this is enough to intubate them. But if not, then propofol or alfaxolone may be adequate, or maybe an appropriate choice for induction of anesthesia. Usually we instrument these patients so that we can keep a very close eye on their cardiovascular system. So they'll generally have a central venous catheter for drug administration and blood sampling, and also arterial catheterization to measure acute changes in blood pressure. Maintenance can be with isoflurane and sevoflurane, and again, in order to reduce the amounts of these vasodilatory drugs, we tend to run alongside infusions, so fentanyl for analgesia and max sparing effect, lidocaine as an anti-inflammatory, and for max sparing effect, and the noradrenaline to help support the blood pressure. We would mechanically ventilate these patients because they are they have a metabolic acidosis, and we want to try and counteract that, perhaps even slightly hyperventilating them to try and normalize the pH as much as we can. In terms of predicting fluid responsiveness, we can use heart rate and blood pressure, but they tend to be very poor predictors of fluid responsiveness. So instead, with arterial catheterization and mechanical ventilation, we have more sensitive ways, such as pulse pressure variation, which are able to detect whether a fluid bolus is likely to improve this patient's cardiovascular system, because giving too much fluid is as detrimental as giving not enough often. This is just a sort of picture from the Anesthetic Monitor that we can check. I don't know if you can appreciate on the bottom tracing, there is a sort of swing where the peak pressure is changing. So you're sort of getting a downward trend which corresponds to the top graph, the square, which is the ventilation. So when you give the breath, we see a decrease in pulse pressure. And if this swing, if the difference between the maximum and minimum pulse pressure are great, then we can be confident that the patient is likely to respond to a fluid bolus. This is just a different monitor that we have, which allows a less invasive way of monitoring fluid responsiveness, so we don't need an arterial line for this. Instead, this is from the pulse ox on the tongue. It again shows us a little swing. I'm not sure if you can appreciate that on the tracing on the bottom, but there's a variation between the pulse amplitude. In terms of post-op care, as I say, the mortality in these cases are still high, so they require really intensive monitoring afterwards. Our aims are basically to provide analgesia and antibiosis and maintaining blood pressure in order to maintain oxygenation of the tissues. But in many of these cases, they will progress to further diseases such as disseminated intravascular coagulation or multi-organ dysfunction syndrome. So really challenging cases. Moving on to something which is again commonly seen in first opinion practice, and we have Spot, a 3-year-old Great Dane who has a sudden onset of retching and abdominal distension. He has been rushed to the vet as he's trying to vomit, but he's not been productive. So he's very stressed, he's tachycardic, mucous membranes are pale, poor pulses, low blood pressure, similar to the presentation from the previous cases, but the emergencies do tend to present in this way. The test conscious radiograph gives quite a clear indication that he has a GDV, and we can add additional tests in to sort of determine the stability of the patient. So hematology often is quite normal, as long as there hasn't been a tearing of any of the mesenteric vessels causing a concurrent hemoabdomen. You may choose to look at biochemistry just to make sure that there's no concurrent disease process in this patient that was present before the GDV. Lactate can give a guide as to whether the prognosis of the surgery. If there is significant necrosis of the intestine, then lactate is likely to increase. Again, you may want to check the coagulation times, but I'd say that's maybe a little bit less important in the GDV case compared to the previous ones we discussed. So because the stomach has turned and inflated, the turning has compromised the blood supply to the stomach and often to the spleen. The dilation of the stomach then puts pressure on the vena cava, which causes reduced venous return to the heart, producing a hypovolemic shock. And also this distension of the stomach inhibits adequate ventilation. Arrhythmias, again, are going to be common in these cases. So in terms of stabilization, we can again give fluid therapy. Again, it's a very common initial first step for stabilization of the emergency patient. And you want to give these through large, short cephalic catheters, and they can be given like quite shock doses, so quite high volumes, like 40 to 50 mils per kilo, very quickly with pressure bags ideally, in order to try and restore the circulating volume to the heart, which has been disrupted by the compression of the caudal vena cava. We can try to attempt to pass a stomach tube conscious if they are cooperative, to try and decompress the stomach, but if not, then we can attempt percutaneous decompression to allow some resolution of blood flow. Pre-medication, again, these animals are often quite flat, so like a methadone dose combined with midazolam and also the addition of lidocaine IV, because arrhythmias are common, and can be given. Your induction agent of choice, propofol or alfaxolone, if you have it, may be slightly more cardiovascularly stable, although that's not conclusively true. You should have suction available in case there is any regurgitation, although that true regurgitation is unlikely if the stomach has twisted. Often the saliva has collected in the esophagus, so it's often quite messy in there. For maintenance, I would go with isoflurane or sevoflurane, and again, similar to the hemoabdomen, lidocaine CRI may decrease the requirement for isoflurane, which will increase your blood pressure, hopefully. In most of the emergency surgeries, non-steroidals are contraindicated, and certainly because of the questionable gastrointestinal viability in these cases, we wouldn't usually give non-steroidals here. In terms of post-op monitoring, it is similar to splenectomy, so if there have been arrhythmias present during the procedure, then you probably want to continue keeping an eye on the ECG during, and you can maintain the lidocaine CRI both for analgesic and mild analgesic effect and also for antiarrhythmic effect. But if you're going to be doing the lidocaine ongoing, it's important to reduce the dose because it can certainly accumulate and you may see side effects of nausea and the decreased mentation. So I would definitely reduce to around 30 micrograms per kilo per minute and maintain that maybe for the overnight period. The final one, we have Sheila. She's a prize-winning French bulldog or bulldog bitch, and she has been bred to give her 7th litter of puppies, but she's having a non-productive labour, which has been happening for 2 hours, and the decision is made to perform a caesarean section. So things that we need to do prior to induction is to get as many staff as possible so that we can have people available to resuscitate the pups when they are delivered. You want plenty of warm, dry towels, ideally an incubator or some warm kennel for the pups once they are thriving. And it's often helpful to have very small ET tubes, although in small breed dogs the puppies are going to be too small for most of the ET tubes, but IV cannulas can be useful just to intubate the glottis and provide oxygen therapy if necessary. So the pregnant bitch has some physiological changes, and they have an increased minute ventilation, so they breathe more per minute in order to provide for the oxygen demand of the fetuses. And this causes an increase in bicarbonate. In order to compensate for the reduced CO2, we have an increased bicarbonate excretion in order to maintain a normal arterial blood pH. But when we anaesthetize them, the hyperventilation disappears, and so these animals can be more prone to acidemia. So it's often helpful to continue to ventilate these guys. Because of the pressure on the chest by the gravid uterus, we have a reduced functional residual capacity, and these patients are at increased risk of desaturation at induction, so pre-oxygenation is important. Turning them onto the back with the gravid uterus can cause compression of the vena cava, so you may want to consider a slightly off dorsal recumbency, so when they're tipped very slightly to one side, just so that the uterus doesn't fall completely on the great vessels in the dorsal abdomen. And it's important to remember that uterine blood flow is pressure dependent, so compared to the kidneys, which can maintain a normal blood flow over a range of values, the uterus blood flow is completely pressure dependent. So if we have hypotension, we're likely to have reduced uterine blood flow. So we want to minimize the anesthesia time that happens while the pups are still in the uterus. So any clipping and pre-prepping can be done while the animal's awake if her demeanour and behaviour allows. I don't tend to pre-medicate these patients. I usually just induce without any pre-medication, especially if they are quiet animals. The more anxious animals I may pre-medicate with, again, maybe a small dose of fentanyl or a low dose of methadone, 0.1 mg per kg. After induction, and the reason I don't pre-medicate is because I usually will try to do an epidural. But I'll only give myself a couple of minutes to do this. Again, I'll have clipped and prepped the space. And if I'm unable to perform the epidural quickly, I'll abandon that and we'll move on to a different technique, which often will include a line block of lidocaine, excuse me, and for additional analgesia, we can consider small boluses of fentanyl, particularly after the pup has been removed. Often you can get away with slightly less isoflurane or sevoflurane because the progesterone produced during the pregnancy is in fact max sparing. So as I say, if you haven't given any pre-med, but we've done a line block, that's with lidocaine is going to wear off quite quickly. So once the pups are removed, you can give additional opioid analgesia. Again, I would usually give 0.1 to 0.2 mg per kg of methadone. And also I would usually, once the animal is recovered, I would tend to give a one-off dose of non-steroidal. There will be some of the drug, both the non-steroidal and the opioid, which moves into the milk, but the concentration is unlikely to be low enough to cause the pup any problems. As I say, perfusion of the uterus is pressure dependent, so if I have hypotension, that will usually be treated with either fluid therapy, so fluid boluses, or ephedrine, if you have that available in the practice, 50 to 100 micrograms per kilo bolus, repeated as required. For resuscitation of the pups, as I say, you want a large team so that the people are available. You want to clean and clear their airway and rub them to stimulate breathing. Bradycardic pups are usually hypoxic or hypoxemic, which is the reason for the bradycardia. So they don't usually respond to anticholinergics such as atropine. In fact, the better treatment is to attempt to intubate them, or if that's not possible, at least to give them face mask oxygen, because as the oxygen increases, the bradycardia should resolve. If you did give opioids before the pups were removed and they are bradycardic, then you can consider to reverse that with naloxone, if you have it available in the practice, and this can be given sublingually, just 1 or 2 drops from a 1 ml syringe. Previously, people have used doxapram to try and stimulate breathing, but there is some controversy as to whether that's effective, and in fact it may increase the oxygen demand in the brain, which, if the animal is hypoxemic, may worsen the pup's viability. The pup viability can be measured based on this modified APGAR score. So the looking at the heart rate, respiratory rate, and how vigorous the animals are in response to a stimulus such as pinching the leg, and can give an idea of how viable they are and whether they're likely to run into problems or not. The reason that I chose alfaxolone for induction in this case is that there are some studies which show a higher APGAR score in pups in the short term, so in the hours after delivery, compared to other induction agents, so that may be one reason to choose alfaxolone for these cases. Though in this paper, I think the actual survival rate of the puppies in the longer period, at 1 month I think it was not different between propofol and alfaxolone. So as I say, once the pups are out, post-op care for the mother, you can give meloxicam or as a non-steroidal, and a low dose of methadone for the anaesthesia. If you have done an epidural, then it's important just to be careful that she's going to be less mobile, so it's important that she doesn't lie on any of the pups or anything like that. So just keep a very close eye in the post-op period. But yeah, that was the 6 sort of cases that I could think of that may be quite common in first opinion practice. I hope it's been helpful. Sorry that it was a little bit fast, and it was quite a few to try and run through in just in the 1 hour webinar. But any questions you have, if you're watching live, I'm happy to take those now. Or if you're watching a recording of this, if you contact London Vet Specialists with your question, I'd be happy to answer those for you. Okay, thank you very much.